Hello and welcome. I'm Dr. Axel Grothe from the West Cancer Center and Research Institute in Germantown, Tennessee. Thank you for your interest in taking aim at GI cancers, new opportunities to deliver personalized treatment with HER2 and other molecularly targeted therapies, a virtual symposium that I recently developed in collaboration with Drs. Kohai Shitara and Geoffrey Koo. Before we begin the main program, I'd like to highlight a few very exciting updates that were announced just during the ASCO GI 2021 annual meeting, which included the recent FDA approval of T-DXd trastuzumab deruxtecan for the treatment of adult patients with locally advanced or metastatic HER2-positive gastric or gastroesophageal junction adenocarcinoma who had received a prior trastuzumab-based regimen. In addition to highlighting a few other important announcements from ASCO GI 2021, I will provide my perspectives on how these recent advances will impact our practice. So to look at the development of targeted agents in GI cancer, it all started with the recognition in a kind of a negative way that EGF receptor antibodies in colorectal cancer did not work in KRAS mutant tumors. This was around 2008, 2009. This was a negative selection. The first positively selected targeted therapy in GI cancers was trastuzumab in HER2-positive gastric and gastroesophageal cancer. This was in 2010, and since then we've seen the emergence of various agents in even tumor-agnostic indications like Pembrolizumab in MSI-high cancers, larotrectinib and entrectinib in NTRK-positive, NTRK fusion-positive cancers. And more recently in pancreas cancer, olaparib for BRCA-positive tumors, FGFR-positive biliary tract cancer. So almost every cancer in the GI world has some targeted agent approach as part of standard of care. I want to highlight most recently there's been a lot of interest in HER2 targeted agents, and we really tap into the experience that we have developed in breast cancer, where a lot of these agents are further along in their development and have already received FDA approval to some instances. And novel HER2 directed strategies really are focusing on new delivery systems for chemotherapy like antibody drug conjugates, in particular T-DXd, and we'll highlight that a little bit more. But there are other antibody drug conjugates in the clinical trials right now, hopefully going to get approved at some point, including HER3 targeted therapies with antibody drug conjugates. And I'll walk through some of these data, new monoclonal antibodies, bispecific antibodies targeting different aspects of HER2, like pertuzumab and the trastuzumab combination combined in ZW25, or bispecific antibodies which try to recruit the immune system. Combination with immunotherapy, of course, that's on our mind, and then kinase inhibitor combination with a novel agent tucatinib, which is likely one of the strongest kinase inhibitor as a small molecule. So highlighting antibody drug conjugate, really what surprised us in a happy way was the approval of T-DXd trastuzumab deruxtecan for patients with locally advanced or metastatic HER2-positive gastric cancer. This was based on the randomized data from the Destiny Gastric study, which was published in the New England Journal of Medicine. And the important point here is that the patients benefited even if they had been pre-treated with trastuzumab or trastuzumab combination. So this is really filling the void of kind of a second-line treatment option for patients with HER2-positive disease that had already received trastuzumab-based therapy. Several other trials had failed. The Destiny trial was the first one that showed a survival benefit. So rightfully, and I think very interestingly, and a good option for our patients, now we have T-DXd FDA approved in a second-line setting. Now, bispecific antibodies, which I briefly alluded to, are also interesting. We saw an interesting abstract at ASCO GI looking at zanidatamab. I still need to learn how to pronounce these words. ZW25, which is a bispecific antibody linking kind of the trastuzumab effect and the pertuzumab effect together in one antibody, really targeting HER2 in different antigen sites. And this agent has actually shown to be very effective, very interesting, and is definitely moving forward in the development, not just in gastric cancer, but also hopefully in colorectal cancer and of course in breast cancer. Now, combination with immunotherapy is a hot topic in various different disease. We've already seen some preliminary data from the Memorial Sloan Kettering group, Yelena Janjigian study combining trastuzumab chemotherapy and pembrolizumab in HER2-positive gastric and gastroesophageal junction cancers. This is now being expanded in the Keynote 811 study, and there are other immunotherapy combinations which are being developed. And the idea is, that HER2 and immunotherapy targeting agents actually would work quite well together. So this is something which I have a lot of hope in, that it will change our standard of care and improve upon the already interesting data that we've seen with immunotherapy in upper GI cancers. So when we put all this together now in terms of, how to integrate this in the management of patients with advanced gastric cancer, I think, of course, initially at the time of diagnosis, we need to assess performance status, a laboratory evaluation, liver function, kidney function, but we definitely also need molecular parameters, PD-L1 staining, and HER2 status. And if we have a HER2 positive cancer, the first line treatment of choice in patients with good performance status is a platinum plus fluoropyrimidine plus trastuzumab-based therapy, which commonly in our hands right now is FOLFOX plus trastuzumab. And in the second line setting, if we see that patients had MSI-high tumors, for instance, or high PD-L1 levels, pembrolizumab is definitely one of the choices and could potentially even move into first-line treatment. Outside of that, ramucirumab-based treatment with paclitaxel, clinical trial, irinotecan as a second-line option, they're all on the table. But if HER2 positivity is still maintained, and this is where we can talk about, do we need to re-biopsy patients, because we know that the HER2 expression level actually changes. T-DXd now is a newly FDA-approved treatment option and should definitely be considered. And if HER2 expression level is no longer given, TAS-102, trifluoridine, tipiracil, or clinical trial can definitely be used. CPS scores, the combined positive score for PD-L1 levels can again identify patients who are candidates for immunotherapy with pembrolizumab. And in other countries, nivolumab is also approved. Now, in metastatic colorectal cancer, interestingly, about 2 to 3% of patients, unselected patients, also have HER2 overexpression, and they are also candidates for HER2 targeted therapies. We've already seen prior data from trastuzumab plus lapatinib, trastuzumab pertuzumab. In the MyPathway study, we've seen emerging data, trastuzumab tucatinib, and of course also for T-DXd, a single-arm study in about 70 patients that looked at trastuzumab deruxtecan as an antibody drug conjugate in patients with HER2 amplified and RAS, BRAF wild-type tumors, colorectal cancers. And this has been integrated by the NCCN guidelines now. So the NCCN guidelines allow as one of the treatment options to use trastuzumab deruxtecan or trastuzumab in combination with either pertuzumab or lapatinib, based on the data that I've mentioned before, as a treatment option in second and third line for patients with HER2 overexpressing metastatic colorectal cancer. Then there are other ASCO GI 2021 highlights. Bemarituzumab, which was one of the highlights in gastric cancer, is an FGFR antibody, and FGFR is overexpressed in about 30% of patients with advanced G-junction and gastric cancers. And the randomized phase 2 FIGHT study showed interesting efficacy data, and I hope that bemarituzumab will move forward in the development. I think there is one of our next targets that we will address in gastric cancer, FGFR. Then some updates from the studies that were presented at ESMO, quality of life assessment of CheckMate 577, the adjuvant nivolumab data in gastroesophageal cancer with residual therapy after trimodality treatment. Quality of life is maintained even with a year of nivolumab as adjuvant therapy. Quality of life assessment of Keynote 590, pembrolizumab and chemotherapy in the advanced gastric cancer setting. And then LEAP-005, interesting and updated data, a combination of pembrolizumab plus lenvatinib, which is an approved option actually in endometrial cancer in the United States. In colorectal cancer, abstract that kind of refined the data that we'd seen, some additional data on Keynote 177, which established a new standard of care in first-line MSI-high colorectal cancer, then updated data on the first-line nivolumab plus ipilimumab data, and further combinations now with panitumumab. Then the Tcga data, which I find interesting, first-line TAS-102 and oral combined fluoropyrimidine plus bevacizumab in colorectal cancer for patients who are not considered candidates for oxaliplatin or irinotecan. Very interesting data. The dostarlimab data as kind of a new PD-1 antibody in mismatch repair deficient solid tumors, and then moving into biliary cancers, which is really a gold mine for targeted approaches, because it's the tumor, in particular intrahepatic cholangiocarcinomas, with the highest yield of targetable alterations, with ivosidenib for the IDH1 mutant tumors and infigratinib for a patient with FGFR alterations. And then we saw somewhat disappointing data from POLO, the phase 3 study of olaparib in pancreas cancer, which in spite of progression-free survival benefit and being compared to placebo, did not show survival benefit in pancreas cancer in the maintenance therapy setting. But still, I believe that olaparib is one of the could be considered one of the standards of care in maintenance therapy. In summary, I think we can all agree that there were some really exciting developments for patients with GI cancers in early 2021 presented here at the ASCO GI Symposium. I'm hopeful that the evidence and personal perspectives that you'll hear from me and Drs. Ku and Shitara will help you to improve the care of your patient with GI malignancies. Thank you, and stay tuned for the complete presentation and discussion segments from our 2021 ASCO GI Satellite Symposium. Thank you. Hello and welcome to Taking Aim at GI Cancer's new opportunities to deliver personalized treatment with HER2 and other molecularly targeted therapies. I'm Dr. Axel Grothy from the West Cancer Center and Research Institute in Germantown, Tennessee, and I'm pleased to welcome my colleagues Dr. Jeffrey Ku from Memorial Sloan Kettering Cancer Center in New York, Dr. Kohei Shitara from National Cancer Center Hospital East in Japan. And here's today's agenda. So we'll first talk about approaching GI cancer with precision, examining the rationale and significance of molecular targeted therapy by Dr. Ku, then evolving the standard care of gastric cancer with novel HER2 and other molecularly targeted approaches by Dr. Shitara. And I will kind of close us off by talking about preparing for the next wave of advances in colorectal, biliary, and pancreatic cancers, targeting HER2 and other critical oncodrivers. So without further ado, I'd like to turn it over to Dr. Jeffrey Ku from Memorial. Please turn it on, take us away from here.
Great, Dr. Grothy, thank you very much. So I'll essentially set the stage for both of your subsequent presentations. I'll talk a little bit about the underlying biology, discuss the rationale for biomarker testing, bioreferencing current as well as soon-to-be available therapies. So starting with this slide, this is a busy slide, and certainly I'm not going to go over all of it, but it really does highlight over time the number of therapies that have become available in GI cancers that do require biomarker testing. I'll focus on a salient few. The first, of course, is the landmark approval of cetuximab and panitumumab in 2009 for colorectal cancer, at the time based purely on KRAS wild-type status. Since then, we see that multiple approvals for immunotherapy, which will continue to increase over time, thankfully. We also see, sandwiching this, the approval of HER2 therapies. In 2010, trastuzumab was approved for HER2-positive gastric cancer, and we see at the other end, a decade later in 2020, the approval of trastuzumab deruxtecan. So these approvals are not necessarily haphazard, and there is a rationale as to why specific drugs have been approved at specific disease sites. And this, of course, relates to the various Tcga subtypes throughout the GI tract. I'll focus again on the stomach and the colon, and also on these 4 specific subtypes. The first is the CIN, or chromosomal instability subtype. This is a subtype that's characterized by recurrent tyrosine kinase amplifications, including, of course, HER2 and EGFR, both of which are targetable. MSI tumors are rare throughout the GI tract. There's a smattering of about 3 to 4% in both the stomach as well as the colon in the metastatic setting. And of course, these tumors are uniquely responsive to immune checkpoint inhibitors and clearly are something we need to identify and certainly something not to miss. The genomically stable subtype is relatively uncommon, but certainly represents a therapeutic challenge, and for now is a therapeutic desert in terms of targets or targeted therapies. The problem is that they don't really have any tyrosine kinase abnormalities and typically have low tumor mutation burden, so are generally unresponsive to immunotherapy. The last subtype I wanted to talk about is really found only in the stomach, and that's EBV-associated gastric cancer. This is relatively rare. In the Tcga analysis, it accounted for almost 10% of tumors, although certainly in the West, in the US, and in our experience, it's significantly less common. What's critical about the EBV subtype is that there is significant overexpression of PD-L1. Based on this and based on anecdotal data, these tumors are also very responsive to immune checkpoint inhibition. So focusing on the ERBB family, this is a series of 4 tyrosine kinases, ERBB1 through 4. ERBB1 is better known, of course, as epidermal growth factor receptor, but we also have HER2 through HER4. These tyrosine kinases are aberrantly activated in multiple cancers and clearly therapeutic targets that are established as well as emerging. So this cartoon gives a little bit better of a depiction. Essentially, there are 4 tyrosine kinases which exist as heterodimers. If there's a ligand that binds to them, they then come together to form dimers, and it's a dimerization that leads to downstream activation of multiple signaling pathways. In this hierarchy, HER2 is preferred, but any tyrosine kinase can bind with any other tyrosine kinase, and therefore both HER2 and HER3 are emerging as therapeutic targets. So this is an interesting figure. Probably until 5 or 10 years ago, most of us would have considered HER2-positive tumors really to be more or less exclusively breast cancer as well as stomach cancer, where about 20 to 25% of tumors are positive either through a combination of overexpression of the protein or amplification of the gene. But it's now pretty clearly established that there are actually multiple tumors that have some degree of HER2 positivity, whether it's at the protein level, the gene level, or much less frequently in terms of HER2 mutations, many of which can be activating. In the GI tract, we certainly see HER2 expression in the bile duct, in the pancreas, as well as in the colon. Something I like to whip up at cocktail parties is also the salivary gland. These are rare tumors, but actually are quite strongly HER2 positive. So the bottom line is that there are actually multiple potential tumor types that are amenable to targeting of HER2. So as I mentioned, there really are 3 kinds of HER2 alterations that we see. First is amplification, which of course is tested by ISH methodologies. Expression or overexpression of the protein is by immunohistochemistry. And finally, much less commonly, we do find HER2 mutations, and these are mostly discovered as part of large next-generation sequencing panels. The one thing I would emphasize is that there are specific differences and criteria for HER2 positivity and HER2 testing in different tumor types. So it's critically important that we apply the right scoring system to the right tumor type. To wit, if we focus first on gastric cancer, there is now a reflexive testing that's endorsed by NCCN and other bodies here in the US. We start with immunohistochemistry, which is a quick and easy assay. If a tumor is 0 to 1 plus on IHC, that's a negative tumor, and essentially we have a final result. Similarly, if the tumor is 3 plus, that's also a positive tumor, and no additional testing is required. So it's only for the IHC 2 plus tumors where additional FISH is required to confirm whether the tumor cells are indeed HER2 positive or HER2 negative. I would note that HER2 positivity in gastric cancer is defined as strong staining in 10% or more of cancer cells. And we should keep this in mind when we talk about staining in colon cancer, which is different. So of course, MSI and NMR testing is also critical. And in gastric cancer, as in other tumors, there are 2 methodologies. By far the easier and more widely available and probably the most commonly performed test is mismatch repair protein testing. And that's a straightforward immunohistochemistry test for the 4 MMR proteins. Loss of any one of the MMR proteins is associated with an MMR deficient tumor. The other methodology is testing of MSI, or microsatellite instability, and that requires PCR and is relatively more complicated. The good news is that there is typically strong concordance and correlation between the MMR status and the MSI status, with rare exception. And I believe most institutions rely much more heavily on MMR testing and would consider MSI testing only under specific circumstances. In addition, MSI or assessment of MSI status is now part and parcel of many next generation sequencing panels, and that's something I'll come back to in the next several slides as well. So certainly something that's relevant to gastric cancer and relatively unique is PD-L1 testing, because of the established role of immunotherapy in several different contexts at this point. It's clear that with regards to PD-L1 testing in gastric cancer, the scoring system that is much more predictive is based on CPS, or combined positive score. And this really involves counting the number of PD-L1 positive tumor cells, but as well as peritumoral mononuclear cells. You see the scoring system shown above. In addition, on the left, you see a flatly PD-L1 negative tumor, and on the right, you see a strongly PD-L1 positive tumor. The one validated antibody for CPS is the 22C3 antibody, although institutions and groups have validated other antibodies relative to 22C3. So turning now to colorectal cancer, the mainstay of testing in colorectal cancer certainly is the assessment of the all-RAS as well as BRAF status. And most commonly today, that's typically obtained as part of next-generation sequencing panels, which give information on up to 400 to 500 different genes. As mentioned in gastric cancer, certainly MSI and MMR testing is also important in colorectal cancer. And again, MMR, IHC is typically most common. Assessment of MSI status is also provided by next-generation sequencing panels, as I had mentioned. Two emerging areas of testing in colorectal cancer are as follows. Based on the fact that HER2 positivity is present in approximately 8% of colorectal cancers, there is also certainly increasing interest and move to test these tumors. Again, the methodologies are immunohistochemistry, FISH, or assessment by next-generation sequencing, which does give an assessment of HER2 amplification status. I would note here that the definition of HER2 positivity in colon cancer is different than in gastric cancer. Here, IHC 3+ is defined as staining in more than 50% of cells. And again, as in gastric cancer, reflexive testing for FISH is performed only when the IHC is 2+. NTRK fusions are something I've not discussed up to this point, in part because they ultimately are very rare in GI cancers. They're rare in stomach cancer, and they're rare in colon cancer as well. NTRK fusions can be detected through a variety of different methodologies, including immunohistochemistry, FISH techniques, as well as various next-generation sequencing panels. I believe that the optimal testing for NTRK fusions remains to be determined at this point in time. So moving from the basic science and the biomarker tests that are available, the question is, how do we begin to integrate this in terms of caring for our patients? Clearly, the administration of systemic therapy to a cancer patient involves a multidisciplinary discussion and planning and input from many of our colleagues. And arguably, the first step involved in ultimately treating a patient is establishing a cancer diagnosis, as well as the status of the biomarkers that I've just discussed. So in this regard, I'll focus on the memorial paradigm, which certainly I think is common to many academic institutions. Clearly, it's critical for us to be talking with our pathologists and to have close collaboration. But what's even clearer is that this collaboration should occur way before we receive any patient samples. Specifically, we should have well-defined paradigms and algorithms in terms of what we're going to test for, so that ultimately we test every tumor sample in the same uniform way. This is critical for ensuring clinical care as well as for research purposes. So focusing first on stomach cancer, our multidisciplinary group has established the following biomarker testing. We start with immunohistochemistry for HER2, MMR, and then PD-L1. We also perform next-generation sequencing with MSK-IMPACT, which again provides information about MSI status, also provides information about HER2 amplification. When there is tissue that's available, we do also do ISH for EBV, and this is arguably as much for clinical care as it is for research purposes. Clearly, these tumors are extremely responsive to immunotherapy, and we don't want to miss them. But in theory, all of these tumors should also be strongly PD-L1 positive, and even if one does not perform EBV testing, we should be able to identify these tumors on the basis of a tumor that has a high PD-L1 CPS score. Now, I actually think that the most important time for picking up the phone or emailing one of our pathology colleagues is if there is a specific question that we have in mind that clearly they would not be aware of, or if there is insufficient tissue. And this happens frequently with stomach cancer, for example, with diffuse stomach cancer, where we sometimes have scant tissue on biopsies. In that case, it is important to prioritize what we want to test, and arguably in that context, one option would be to perform immunohistochemistry for PD-L1, and that's information that cannot be obtained in any other way, and then to just perform next-generation sequencing. That kind of serves as a one-stop shop, and again, would give you information about HER2 amplification, and does also offer information about MSI status. Another heuristic that I sometimes use is that if we're dealing with a diffuse type gastric cancer, HER2 positivity in these tumors is less than 5%, versus the 20-25% rate that we normally think of. So if tissue is limited and we think it's likely that the tumor will be HER2 negative, it's not ideal, but maybe we can forego testing under those circumstances. For our colorectal cancer patients, our panel is much more straightforward. Clearly, the most important test is next-generation sequencing. And again, it gives you information about all RAS and BRAF status, MSI status, as well as HER2 amplification. I would add that HER2 amplification on next-generation sequencing correlates reasonably well with HER2 amplification on FISH, which in turn correlates well with HER2 overexpression by IHC. For our colon cancer patients, we also typically do perform IHC for mismatch repair protein status, but at this point, we are not routinely performing IHC for HER2, and we're certainly not doing separate testing for NTRK fusions at this point in time. Finally, the last part of my talk will involve just quickly going over the algorithm for treatment of advanced gastric cancer as well as advanced colorectal cancer. So starting with advanced gastric cancer, for patients who have a good performance status, the standard of care around the world really is a fluoropamidine platinum doublet. We add trastuzumab to tumors that are HER2 positive. This is an evolving standard of care, and we likely will be incorporating immunotherapy both for HER2 negative as well as HER2 positive tumors in the near and slightly further long term. For patients with a poor performance status, best supportive care is most appropriate. For patients who do start on first-line therapy and who maintain a good performance status, the standard of care for the last 6 years now is ramucirumab, paclitaxel. Irinotecan is also active in this context. If a tumor is MMR deficient or MSI, and again, that comprises about 3 to 4% of advanced gastric cancer, then pembrolizumab has been FDA approved. One could argue also under certain scenarios to actually move the use of immunotherapy up to the first-line setting for such patients. In the third-line setting, pembrolizumab is approved as treatment for tumors that are PD-L1 positive with a CPS score of 1 or more. Irinotecan is an option. TAS-102 is also a drug that's been approved for several years now. And as Dr. Shitara will discuss, there are emerging promising HER2-positive therapies, including trastuzumab deruxtecan. And finally, focusing on the standard of care in colorectal cancer, undisputedly the champion of the most commonly used regimen in the first-line setting is bevacizumab FOLFOX, and this can be given without regard to the sidedness of the tumor and without regard to mutational status. Bevacizumab FOLFIRI clearly is therapeutically a comparable option, but tends to be much less commonly used. I believe only about 30% of U.S. oncologists administer this relative to bevacizumab FOLFOX. However, proponents of FOLFIRI will argue that there are no cumulative side effects and that it can be continued indefinitely. On the other hand, we all know oxaliplatin has to be stopped, typically after 3 to 4 months because of a worsening neuropathy or increasing risk of neuropathy in any case. Certainly, there's a role for EGFR antibodies in left-sided tumors, in tumors that are all RAS and BRAF wild type. It's certainly considered standard of care in Europe, probably in large part because of the positive German FIRE3 study, but really has not been widely adopted in the US, in part because the CALGB 80405 study did not show superiority of EGFR therapy over the use of bevacizumab in the first-line setting. FOLFOXIRI is the triplet chemotherapy regimen. I think its use is somewhat controversial. There are data to suggest that in BRAF V600E mutated tumors, this is an optimal chemotherapy regimen, although I don't think that these data have been universally accepted. Certainly, I think there is potentially a role for this 3-drug regimen in patients who are young, in patients with good performance status, in patients with high disease burden, for whom we need maximum tumor shrinkage. Relatively recently, pembrolizumab is now an option in the first-line setting for tumors that are MSI or MMR deficient. And as Dr. Grothe will discuss, trastuzumab-containing combinations, trastuzumab with pertuzumab and trastuzumab lapatinib, are now included in NCCN guidelines for HER2-positive colorectal cancer that is also RAS and BRAF wild type. So with that, I'll end my talk. Thank you very much.
Yeah, thank you very much, Jeffrey. So let's have a panel discussion about these points. And there are some points that I'd like to discuss, So what are the practical challenges that you encounter? And I'd like to talk about, the kind of a multidisciplinary approach and multi-regional approach, Japan and the US, potentially tapping into some experience we have from our European colleagues. What are the key issues and practical challenges, consideration related to HER2 and other targeted therapy testing and multidisciplinary care for patients with GI cancers? Is everyone moving toward using NGS panel testing right up front? Is this what we're doing? Dr. Ku, you mentioned the immunohistochemistry versus testing for amplification for HER2, for instance. Is that really in colon cancer the way to go? Can we kind of easily forgo on immunohistochemistry? And I'd like to get Dr. Shitara's opinion from a Japanese perspective here.
Yeah, so I think the biomarker test is very important for various types of tumor, including gastric cancer. In my clinical practice, I check not only for HER2 and MMR, but also PD-L1 expression, as well as the EBB, FGFR clouding, and EGFR, because they are a kind of clinical ongoing trial to investigate a targeting therapy. In Japan, unfortunately, NGS is only approved for patients after standard of care, almost like a phase 1 patient population. So in not a few trials, NGS is not commonly used. In our clinical practice in our hospital, we do research to incorporate NGS and ctDNA analysis, so not a few patients undergo these tests. But again, NGS is not so commonly used in Japan because of this kind of indication and the reimbursement issues. So this is the current situation of biomarker tests here in Japan.
So is NGS testing not used up front or at any time in the course? Because, there are two different philosophies. In our center, we use NGS testing right up front to profile the cancer and see, kind of really put patient on a track, what other treatment options are available down the line, including clinical trials, etc. And some people do kind of a last resort. We've run out of treatment options, and now we need to find these 10, 15%, sometimes less than that might respond to one certain targeted approach. So do you never do it, or do you do it at a later time point in Japan?
Oh, thank you. So in Japan, NGS is commonly used in later lines of treatment, just before all-comer phase 1 or after standard of care, according to approved label, because of it is used to seek targeting therapy in clinical trials. But in our hospital, we do a clinical research to use NGS in tumor and ctDNA. So we try to use NGS in more earlier lines of treatment.
I do recognize that most patients are not treated in academic institutions. Especially in the United States, we talk about 70% of patients are treated in a community setting. So at some point, we need to really kind of move this academic approach to, patients, across the country. And Jeffrey, we know that, patients can benefit from larotrectinib, entrectinib in a significant way when we identify these patients, few patients with NTRK fusions. And I remember I have about 3 patients in my clinic in the last 2 years where we have an NTRK fusion One was esophageal cancer, one was actually breast cancer and a salivary cancer, actually thyroid cancer. And but if we don't test up front, we never find those patients. We have these drugs. So what's the approach from Memorial's perspective?
Yeah, and I would certainly be interested in hearing, your approach as well. But I think at the end of the day, we're talking about something that's extremely rare, and I think by all accounts in gastric and colon, maybe a 1% incidence. And especially in gastric cancer, where we frequently have limited tumor sample based on an endoscopic biopsy. The question is, where are you going to get your biggest bang for your buck? And NGS is not perfect, but it can pick up NTRK fusions. I'm certainly not an NTRK maven. My understanding is IHC actually can have reasonable sensitivity, maybe comparable to some of the DNA or ISH-based techniques. So maybe I think if ultimately there is an IHC that's validated and doesn't require a lot of material, then I think it may make sense. But it's a little bit of it's actually a little bit of a risk-reward calculation in the sense that if we're using up precious, tumor material for something that's very, very rare, then it may not be justified. Certainly, that's our rationale for not having specific NTRK testing, both in gastric as well as in colon cancer at this point in time.
But I think it goes beyond NTRK. I mean, because if we have panels, we discover alterations that we've normally not discovered before. I mean, right. We are talking about tumor mutational burden. We're talking about POLE mutations. I mean, we identify BRCA mutations in various diseases, which could lead us to new treatment options. So I think the trend that we observe, at least in the US, is really more comprehensive molecular profiling up front, to really identify patients who could be candidates for standard of care, because standard of care is evolving. I mean, HER2 targeted therapies, we talked about NTRK, MSI targeted therapy. There are a lot of different treatment options that we have. I mean, it's a challenge, not just for gastric cancer, colon cancer that we focus on, but we have other cancers like biliary cancers, pancreas cancers. Now we're talking about really, our treatment approaches are so sophisticated that we're talking about one change of an amino acid, KRAS G12C versus G12D, right. Might make a difference whether or not you have a therapeutic approach. So I think, having upfront testing, I think can help patients really go on a track toward, a different treatment approach in the idea of continuum of care, So I think that's really interesting. Dr. Shitara, what about, you mentioned ctDNA. Mm-hmm. Which of course would go to the word, what Dr. Koo said, depleting tumor tissue, whatever. ctDNA is there. At least, when patients have a certain amount of cancer or certain tumor locations, metastasis, whatever. How often and how do you use ctDNA in your clinical practice?
Yes, we have a research. Unfortunately, ctDNA analysis is not yet being approved in Japan for cancer patients, but we have a research. So I try to do ctDNA assessment, especially patients after molecularly targeting therapies, to follow the resistant mutations, or a patient who have a not good tumor to do a biopsy. So to replace the tumor biopsy to detect the mutation. So in general, in my gastric cancer patient, more than half, nearly 80% of patients underwent a ctDNA assessment during any lines of treatment course.
But you consider that research, or is it part of your practice?
This is research. As mentioned, ctDNA is not approved and not reimbursed in Japan, so we need research to do it.
Jeffrey, what do you think?
I think it. I think for us, it for now remains in the realm of the experimental. I mean, I think clearly there are lots of things about ctDNA that are attractive. I personally am a little bit skeptical as to whether the addition of ctDNA will ultimately help us in terms of monitoring response to therapy. I think it's critically important for identifying, maybe potentially, biomarkers of resistance or early resistance. But the question ultimately is whether we have some, other treatment that we can intervene with that will ultimately, benefit a patient. So I think these are, I think for this reason, I think almost for everyone in our group, it remains, it's certainly not routine. It's mostly experimental. I would say the one situation where I would consider ctDNA testing in place of next generation sequencing is if I absolutely have no way of getting any tumor tissue. But certainly, I think for now, I would not consider it a direct substitute for next generation sequencing of tumor tissue. I think it really remains experimental in any number of different contexts. And again, disease monitoring, biomarker resistance, minimal residual disease assessment. But clearly, it's a tool that probably will become more established in the next 5 to 10 years in standard clinical care.
So one of the very important characteristic of ctDNA assessment is very short turnaround time. So we can get the result very quickly. So this is very good for us to stratify patient into treatment or trial.
Yeah, that's a good point. I mean, turnaround time are fast, and particularly if you have to find your tissue from outside pathology when you get cancer patients referred to the institution, and
I guess the last thing I would quickly add is, of course, kind of tumor-educated ctDNA testing is really the most beneficial. I mean, if you also have next-generation sequencing of the tumor, that way, you know the specific mutations that you're trying to identify, and that can certainly increase the sensitivity. So I think the two certainly go hand in hand. I mean, I think clearly, it is very promising, but I'm not sure that it has any current standard clinical application. Many research applications.
Perfect. Okay, so let's move on. And Dr. Shitara, I'd like you to kind of take over here and talk about evolving the standard of care for gastric cancer with novel HER2 and other molecularly targeted approaches.
Thank you, Dr. Grossi, for very kind introduction. So I will be discussing standard of care for gastric cancer with novel HER2 and other targeting therapies. So as you know, HER2 is one of the important targets for gastric cancer. Pivotal Tcga study established chemotherapy plus trastuzumab as a standard first line for HER2-positive gastric cancer. Exploratory analysis showed a clear survival benefit in patients with either H3 plus or 2 plus with FISH positive. So this is a current consensus of HER2-positive definition. Unfortunately, subsequent several randomized studies failed to show survival benefit of other HER2 targeting therapies, including pertuzumab, lapatinib, and T-DM1 as an antibody-drug conjugate. So these results are quite different from many successes for breast cancer. There are several possible reasons for resistant mechanism of currently available HER2 targeting therapies. And among them, most important characteristic in gastric cancer are intratumoral heterogeneity of HER2 expression. So we need a new treatment to overcome. So now emerging novel therapy are investigated for gastric cancer, including new antibody-drug conjugate, newer monoclonal antibodies, combination with immunotherapies, and the newer tyrosine kinase inhibitor. So I will introduce some of these new treatments. Trastuzumab deruxtecan, also known as T-DXd, is a newer HER2 targeting antibody-drug conjugate composed of anti-HER2 antibody, cleavable linker, and a DNA topoisomerase inhibitor payload. T-DXd has a higher drug-to-antibody ratio compared with other ADC, such as T-DM1. In this figure, mode of action of ADC is explained. T-DXd binds to a HER2 receptor and is internalized into the cancer cells. Then, linker is cleaved by the intracellular lysosomal enzyme, such as cathepsin, and the payload is released. This payload prevents DNA division and induces cancer cell apoptosis. At the same time, this payload is also released outside the cell membrane because of high permeability, then attacks the surrounding HER2-negative cell. This is called bystander effect, which is especially important for tumor with heterogeneous HER2 expression like gastric cancer. Actually, T-DXd showed anti-tumor activity in T-DXd-resistant cell line or a mouse model with HER2 low expression. Destiny Gastric 01 is a multi-cohort study of T-DXd for gastric cancer, which was conducted in Japan and Korea. Eligible patient for randomized part had HER2 positive status by central assessment using most recently available tumor samples. Patients should have also received at least 2 prior lines of chemo, including trastuzumab. Patients were randomized to either T-DXd or physician choice chemo or with irinotecan or paclitaxel. The primary endpoint was objective response rate, and overall survival as a key secondary endpoint was also evaluated if the primary endpoint showed a positive result. This trial met the primary endpoint. Objective response rate was significantly higher with T-DXd compared with chemo, 51% versus 14%. Confirmed response rate lasting more than 4 weeks were also higher with T-DXd. As you can see in the waterfall plot on the right side, most patients achieved some degree of tumor shrinkage with T-DXd. This trial also showed statistically significant improvement in overall survival. Median survival was 12.5 months versus 8.4 months. Hazard ratio was 0.59 with a significant p-value. So that Kaplan-Meier curve showed a good separation from the beginning, and the difference was maintained after a follow-up period. PFS was also improved with a hazard ratio of 0.47. One-year PFS rates were 30% with T-DXd and 0% with chemo. And actually, these results led to Japanese approval of T-DXd in last September, and FDA breakthrough designation of T-DXd for HER2-positive gastric cancer. The most common grade 3 or higher adverse events were bone marrow suppression in both arms with a higher incidence with T-DXd, but most of them are manageable by dose modification. Of note, around 10% of patients with T-DXd experienced drug-related interstitial lung disease or pneumonitis, so this is a very important toxicity. Actually, most of them were with grade 1 or grade 2 and improved after discontinuation of T-DXd. There was one treatment-related death with T-DXd by pneumonia with unknown etiology. And now phase 2 study in Western patient population is also ongoing. This Destiny Gastric 02 study enrolled patients at the second line with a HER2 positive status in fresh biopsy sample. This trial will hopefully confirm the promising result of T-DXd in a non-Asian patient population. So let's move to other agent for gastric cancer. PD-1 blockade is one of the very important treatment for gastric cancer. Both nivolumab and pembrolizumab showed activity in salvage line treatment setting. In second line, pembrolizumab did not show improvement in survival compared with paclitaxel for PD-L1 positive, defined as CPS 1 or higher gastric cancer patient. But efficacy was enhanced in patients with higher CPS or MSI high population. And this result was also suggested in first-line KEYNOTE-062 study. In front-line, there are 3 trials to evaluate chemotherapy plus anti-PD-1 therapy, including KEYNOTE-62, CheckMate 649, and Attraction 4 trial. So this is a summary of these results. Most importantly, CheckMate 649 study showed survival improvement with oxaliplatin-based chemotherapy plus nivolumab in patients with CPS 5 or higher population. Median survival was improved from 11 months to 14 months with a hazard ratio of 0.71. Survival was also improved in CPS 1 population or all population as secondary endpoints. In contrast, Attraction 4 study in Asian countries did not show improvement in overall survival because of a high crossover rate with the subsequent anti-PD-1 therapies. But PFS was clearly improved with chemotherapy plus nivolumab in Attraction 4 trial, so these results suggest that chemotherapy with nivolumab may become new standard of care in frontline after its approval. Anti-HER2 and immunotherapy has a rationale to combine. anti-PD-1 therapy may potentiate ADCC activity of trastuzumab, and anti-HER2 may enhance the T-cell response after PD-1 blockade. And actually, in vivo studies suggested the synergistic activity. This phase 2 study of 4-drug combination showed very promising activity with response rate of around 90% with estimated median PFS more than 1 year. So currently, a phase 3 trial KEYNOTE-811 is ongoing to confirm these promising results. Margetuximab is Fc-modified monoclonal antibody for HER2 with enhanced ADCC activity compared with trastuzumab. Margetuximab showed single-agent activity in trastuzumab-treated solid tumors. Also, recently, this margetuximab was approved by FDA for pretreated HER2-positive breast cancer. In gastric cancer field, margetuximab in combination with pembrolizumab was investigated in phase 1b trial, which showed 30% response rate in HER2-positive in ctDNA, with median PFS exceed 5 months. So now phase 2-3 study is ongoing to investigate margetuximab in combination with immunocheckpoint inhibitors. ZW25 is a newer bispecific antibody with the same binding site with trastuzumab and pertuzumab. ZW25 results in more efficient binding to the epitope or internalization compared with a 2-drug combination with trastuzumab and pertuzumab. And actually, single-agent ZW25 showed promising activity for HER2-positive solid tumors, including gastric cancer, and updated result presented in this ASCO GM meeting. And now phase 2 study of ZW25 in combination with chemotherapy or checkpoint inhibitor is ongoing. CD47 induced do not eat me signal, which prevent phagocytosis from macrophage. Blocking antibody for CD47 redirect macrophage from M2 to M1 and enhance their phagocytosis, enhance their activity of a molecular targeting agent like a HER2 targeting agent, a PD-1 blocking agent. And actually, more than 60% response rate was observed with CD47 antibody in combination with paclitaxel, ramucirumab, and trastuzumab for gastric cancer. In preclinical study, T-DXd showed activation of dendritic cells and increased MHC1 expression. So synergistic activity was observed in mouse model. So combination with T-DXd and a checkpoint inhibitor or cytotoxic chemotherapy is now investigated in phase 1 and 2 Destiny Gastric 03 study. So with that, this is a summary of ongoing trials for HER2-positive population. HER2 is a relatively small population, but many trials are now ongoing, and I hope some of these trials will improve outcomes. So looking into other promising treatment, FGFR2 is one of the emerging targets for gastric cancer. FGFR2 amplification is detected in around 5% of gastric cancer patients, and FGFR2 overexpression is observed in around 30% of patients. Pembrolizumab is a specific antibody for FGFR2b with promising single-agent activity. And recently, it was press released that this pembrolizumab in combination with first-line chemo showed promising efficacy in FGFR2-positive gastric cancer in first line. Hazard duration in overall survival was 0.58, and the details are reported in this ASCO GM meeting. Claudin 80.2 is one of the tight junction protein, which is highly expressed in around 30% of gastric cancer patients. Zolbetuximab is an anti-Claudin monoclonal antibody, which showed a very promising activity as a combination with first-line chemotherapy. And now 2 phase 3 trials are ongoing. So now precision therapy is coming in gastric cancer field. HER2 is an established biomarker for trastuzumab or T-DXd treatment. MSI high patient is a good candidate for immunocheckpoint inhibitor in earlier lines of treatment, and chemotherapy plus nivolumab may become new standard of care in frontline, especially in patients with PD-L1 CPS5 or more population after its approval. Also, there are other emerging biomarkers for targeting therapy, such as FGFR2 or Claudin 80.2. So next, let's discuss one of our gastric cancer patients. This is 65-year-old male with HER2-positive gastric cancer. He was treated with a first-line chemotherapy with trastuzumab, but unfortunately, he experienced disease progression in lung metastasis at 6 months. So what is the next step? So here, I would like to ask opinion for rebiopsy for other experts. So, Dr. Koo, do you perform rebiopsy for all patients after first-line chemo?
Yeah, Kohei, that's a great question. Thanks for asking that. I mean, I think something I certainly try to convey in all these different forums is that it's absolutely important to rebiopsy at the time of progression on HER2-based therapy if one is considering, at this point in time, experimental HER2 therapy in the second and third line setting. I mean, it's pretty well established that about 30% of tumors lose HER2 positivity at the time of progression. Either they lose HER2 positivity as a mechanism of resistance, or it could be because of tumor heterogeneity that they were never HER2 positive to begin with. But yes, I mean, our practice is that if someone progresses on, for example, trastuzumab FOLFOX, we try to biopsy a progressive site. If that site remains HER2 positive, then we would consider an experimental HER2 strategy. If not, if the tumor is HER2 negative, then I think, as you've indicated, ramucirumab paclitaxel would be standard of care. I think that if one is in a setting where access to experimental HER2 therapy is not available, I don't know that there's a compelling rationale to biopsy, since it's not going to affect treatment decisions. But certainly for us, we would rebiopsy. Is that your practice as well?
Yeah, so most of the comment I agree. In my practice, I try to do rebiopsy as possible. But I think currently this is not mandatory for all patients, because paclitaxel and ramucirumab is the best second line in treatment based on Rainbow study. And actually, our T-DXd approval in Japan is only third line or later line. So I do not do all patients, but try to do in most cases. So how do you think, Dr. Grossi, about it?
I mean, I think, we have the kind of a lot of trials that actually failed using HER2 targeted therapy in second-line therapy without patient selection. So I do believe there are some patients who still benefit from anti-HER2 therapy, but based on the fact that we see, downregulation, the disappearance of HER2 positivity in a second-line setting after prior treatment with trastuzumab, I agree with Dr. Koo, that this is really what we should do. We should biopsy, in our shop at least, where we have access to HER2 targeted therapies in a second and third-line setting in clinical trials and outside, compassionate use programs, etc. We do biopsy the progressing lesion if it's feasible, technically feasible, to see whether there's HER2 overexpression is maintained. So I think, this is really talks about the selection over time, and also shows, that cancer cells are dynamic. We know this from HER2 more than from any other things, before, because, this is really something that cancer cells downregulate, over time as a resistance marker to our treatments. So I think, we learn more when we rebiopsy, and we can adjust our treatments better over time.
So Dr. Shitara, I actually wanted to ask you a question. So it's actually come up in the context of your Destiny Gastric 01 study. Again, it was a third-line study, and my understanding is that pre-treatment biopsies were not mandated, yet this was a strongly positive practice-changing study. I don't know whether you can share, what proportion of patients on that study did have pre-treatment biopsies, and whether the fact that not everyone did, but the study was still positive, whether that affects your thinking about the need for biopsies.
Yeah, this is a very important point. We do not report the detail of the types of biopsy and the sample in manuscript and presentation in ASCO or others, but we will present the detail in the future. And actually, most patients are enrolled with a HER2 test in archival tumor tissue in before second line. But some patients also enrolled at HER2 positive status after second line, and some patients also enrolled with a fresh biopsy. So honestly, this is a little bit mixed patient population. So currently, biomarker analysis is ongoing to compare archival tumor tissue and fresh biopsy tissue as well as the ctDNA. So we will present a detailed result in the near future. So I think it may more clearly enrich the patient population to receive a T-DXd. So I want to go back to my case. So again, if this case showed HER2 negative status, paclitaxel and ramucirumab may be the best second line. And if patient had HER2 positive status, he may be candidate T-DXd in second line clinical trial or third line. What we can do if this patient had HER2 low status. So here I would like to introduce a result from our Destiny Gastric 01 trial to investigate HER2 T-DXd treatment for HER2 low patient population. Important difference from previous randomized part is that all patients did not receive trastuzumab before study enrollment because HER2 low is not candidate for trastuzumab treatment. Around 20 patients were enrolled into both IHC2 plus with fission negative or IHC1 plus. Confirmed response rate was 26% with IHC2 plus and 10% with IHC1 plus. So these response rates were lower than that of a primary cohort, but maybe higher than other available treatment options in later lines such as FDD-TBI. Median PFS was 4.4 months with IHC2 plus and 2.8 months with IHC1 plus. So these results suggested that IHC status might be important to predict the efficacy of T-DXd, but they still suggested some clinical activity of T-DXd for HER2 low gastric cancer. So as mentioned before, additional biomarker analysis using fresh biopsy sample or ctDNA from these all patient population is now ongoing, which may clarify exact population to be treated with T-DXd. So overall, we have a promising agent investigated in clinical trials. In frontline, combination with checkpoint inhibitor and anti-HER2 are tested in clinical trials. At this time, paclitaxel plus ramucirumab is standard therapy, even for HER2 positive case. But in third line, we have now results from T-DXd, which showed a very positive result. And many trials are still ongoing. Thank you for your kind attention.
This is great, thank you. And I think we have some questions from the audience here. And one of the questions refers to the management of ILD, interstitial lung disease. And I think, Dr. Shitara, you probably have most experience with T-DXd. So how do you monitor patients? How do you treat patients if you suspect ILD?
Thank you for asking a question. Yes, this is a very important toxicity. And I think early detection of ILD and pneumonitis is very important. In clinical trials, CT scans were performed every 6 weeks, so it is important to check chest CT for early detection. And also, education for patients is also important about possible symptoms such as cough, fever, and dyspnea. If there is a sign of ILD or pneumonitis in CT scans, differential diagnosis with ILD and other lung disease, such as infection, because now is a COVID-19 era, it is also very important. Also, it is recommended to consult pulmonologist as early as possible to decide their diagnosis and management. And if ILD or pneumonitis is strongly suspected, early administration of corticosteroid is also very important.
So that's really what you do. I mean, do you monitor every patient with pulse oximetry? And is your treatment approach mainly kind of holding T-DXd and then giving corticosteroids? Any other tricks up your sleeve that you might have?
So first, I check pulse oximetry for most patients in every visit because it was also requested in clinical trials. But in my opinion, SpO2 is not useful for early detection for asymptomatic, very grade 1 pneumonia. So chest CT is more important. If we have a grade 1 pneumonia, in Japanese recommendation, T-DXd is once stopped, even for grade 1. In our first phase 1 study, patient can continue with grade 1 pneumonitis, but after several toxicity, now Japanese label recommendation after approval recommend stop T-DXd even after grade 1 pneumonitis.
It's an interesting class effect that we see sometimes from the ADC. It's not the first drug that does produce interstitial lung disease, but it's definitely something that we need to pay attention to, especially with T-DXd in various cancers now coming about. Breast cancer approval, we see gastric cancer, the colon cancer data. This is a very active agent, so we need to learn how to use it. Dr. Koo, a second question that comes in from the audience about, the standard of care, paclitaxel, ramucirumab. When you have a HER2 positive cancer, in second line now, how effective is this combination? Do we have any data whether it's different, whether there's a different efficacy between HER2 positive, HER2 negative tumors?
Yeah, I would have to go back and look at the manuscript to see whether whether that was something they looked at. But certainly, I'm not aware that there's a differential effect of ramucirumab paclitaxel based on HER2 positivity versus HER2 negativity. Certainly, I would have no concerns about offering, ram paclitaxel to a HER2 positive patient in the second line setting if we did not have access to an experimental HER2 strategy.
When I look at it, so two comments from my point, HER2 positivity in gastric cancer it doesn't have the same prognostic value as in breast cancer. So that's a different, a different biology. So right. I would expect, there's a similar response rate, HER2 positive, HER2 negative for the non-targeted approaches. On the other hand, the other editorial comment I like to make is that the contribution of ramucirumab to really improving outcome, it's not as strong as we like it to be. Let's say, I do believe there is a need for better second-line therapy. So second-line therapies, it's definitely an area where I believe, gastric cancer could really have some, improvements, Dr. Shitara, any overlap between HER2 and MSI that you observe?
Yeah, this is also important because both is a very important target for HER2 targeting therapy and the checkpoint inhibitor. In a large cohort like a Tcga, there is almost no overlap between HER2 amplification and MSI high status. As mentioned before, we routinely check MMR, HER2, and other biomarker in gastric cancer preparation. And recently, I have one case with overlapping with MSI high and HER2 positive status. Actually, this is a patient with relatively heterogeneous HER2 expression. And MMR deficient was observed in HER2 low space. And we start with the first line for Pembrolizumab and trastuzumab for this patient. And this patient finally experienced disease progression at one lymph node metastasis and the gastric primary. And then second line Pembrolizumab is very effective. And recently this patient underwent a curative resection. So I only experienced one cases.
Okay, very good. I see the interesting data that Yelena Janjigian, has, with a combination of immune checkpoint inhibitors or two targeted agents. It's going to be very interesting to see. There's a lot going on in terms of targeted therapies, in combination of targeted therapies, immunotherapies, and upper GI cancers. And this is a new field which is really exciting. So let's move on to the last part of the presentations, and it's my pleasure to talk about the next wave of advances in colorectal, biliary, and pancreatic cancers targeting HER2 and other critical oncodrivers. And let's start with colorectal cancer. And colorectal cancer, of course, is a very important cancer in terms of prevalence and mortality. And we have really come to realize that colorectal cancer is not one disease. We subdivide it depending on the molecular profile that we have. We already talked about, Dr. Koo talked about, the importance of upfront molecular profiling, particularly with regard to RAS mutational status, MSI, BRAF, but also HER2. And the prevalence of HER2 positive disease it's low actually overall, 2 to 3%. But if you refine the patient population in terms of the left-sided tumors, RAS, RAF, wild type, not responsive to EGF receptor antibody therapies, actually HER2 prevalence actually goes up to the 20 to 30%. And that is definitely an interesting target because we have data from clinical studies, various clinical studies, single-arm studies here in this setting, and mainly which have been conducted in recent years that show clearly there is benefit from HER2 targeted approaches, whether it's trastuzumab, lapatinib, trastuzumab, pertuzumab, tucatinib comes into play, T-DXd that we talked about in a later line setting. And we've seen reliable response rates, which you normally do not achieve in a later line setting with standard chemotherapy, with interesting progression-free survival and duration of response. So let's dive a little bit more into detail and really picking up what we talked about, T-DXd, this antibody drug conjugate. We have actually data in colorectal cancer with the DESTINY-CRC01 study, an international collaboration, which picked up on what Dr. Shitara talked about, high expressor cohorts and low expressor cohorts based on immunohistochemistry and ISH testing. And the data that we've seen so far that are most intriguing are cohort A in the study, in this single-arm study that looked at 53 patients with HER2 positive disease based on immunohistochemistry 3+ or 2++ ISH positive. Importantly, these patients were allowed to have prior anti-HER2 therapy. And so the data were quite interesting because 45% of patients had a response in this high expressing cohort, mainly partial responses, one complete response. Duration of response was intriguing because at the time of the data analysis, it was not yet reached, but there was no response observed in HER2 low cancer, so the IHC 2+ and 1+, which is different than what you just heard in gastric cancer and different what we have actually seen in breast cancer in some studies. So this is it shows the importance of really talking about tumor location, tumor histology, that might impact, the efficacy of these otherwise tumor-agnostic agents. Progression-free survival, overall survival here on the slide, clearly clear evidence that cohort A, the HER2 positive cohort, benefited where the other cohorts B and C did not benefit as much. And actually these data are way beyond what we would normally expect with standard chemotherapy approach in this HER2 positive cohort. We already talked about some of the safety events. This is chemotherapy, which is just targeted. So there are some chemotherapy related toxicities, but in particular, I think what we talked about already is the idea of we need to monitor patients for pneumonitis, interstitial lung disease, because in the colorectal cancer study, actually 2 patients had grade 5 events based on pneumonitis/interstitial lung disease, which is a little bit different than what we saw in breast cancer and in the gastric cancer study. So this definitely raises a flag and needs to be monitored. HER2 targeted approaches are currently being tested actually in the SWOG second-line randomized study looking at pertuzumab, trastuzumab, 2 antibodies against HER2, comparing it to the so-called standard of care, irinotecan cetuximab in the second-line setting. The study allows a crossover, so hopefully the study will be able to accrue, although of course the recent changes in the NCCN guidelines, which now allow us to use HER2 targeted agents in HER2 positive cancers, make accrual to the study a little bit difficult. Now, talking about pancreatic cancer, biliary cancers, pancreas cancer, biliary cancers have their unique molecular profile, and with the advent of comprehensive molecular profiling in a lot of cancers up front, like in our institution where we profile every patient with stage 4 disease right at diagnosis, we really identify subtypes of cancers with the idea that we hopefully find some targeted approaches for these cancers. In particular, biliary cancers have a high yield of targetable approaches. It's actually the cancer which in the GI which has the highest likelihood of finding a target for approved or soon to be approved targeted approaches. About 40-50% of patients with, in particular, intrahepatic cholangiocarcinomas are candidates for targeted intervention. But the problem that we, of course, see in pancreatic cancer, it's a little bit more, let's say, we have less evidence for these targeted approaches, not a lot of clinical studies that have shown that these agents, that targeted approaches work. Although if we all combine the potentially active approaches for the low percentage of patients with BRAF inhibitors, some patients with MSI tumors, we talked about NTRK before, when we combine all these approaches together, we think about that 25% of pancreatic cancers might have potentially actionable molecular biomarkers. And I want to highlight, of course, something that is part of our standard of care, which is BRCA1 and 2, so the DNA repair deficiency that we test for as mechanisms which confer sensitivity to PARP inhibitors. This is something we actually now test as standard of care. Every patient with pancreas cancer that gets diagnosed with advanced disease and actually local regional disease should be tested for BRCA mutation, germline mutation, for various reasons, familial screening, but also identifying patients that might be candidates for PARP inhibitor therapy. We have phase 3 data from the POLO study that looked at patients with BRCA, germline BRCA mutated metastatic pancreatic cancers. They had at least did not progress on first-line platinum, mainly oxaliplatin-based therapy, FOLFIRINOX. And they were randomized to maintenance, olaparib, or placebo. There was clear benefit in terms of progression-free survival, not necessarily overall survival, for patients who continued on olaparib. So there is proof of principle of an activity of this PARP inhibitor. I want to highlight that in this study, when they screened patients, only about 7% of patients were actually germline BRCA mutated. So that's a small patient population, but it's an important patient population. These patients have platinum sensitivity, and they have a treatment options, at least in this trial setting here, for olaparib. And there are other DNA damage repair mechanisms that might confer, let's say, sensitivity to platinum agents and targeted agents that interfere with further DNA repair mechanisms like PARP inhibitor, etc., as identified here on the slide. So this is actually a very active area of research, and I hope that we can identify more agents, more approaches to improve outcomes for our patients with pancreas cancer, because that's clearly an unmet need. Now, I already mentioned, actionable alterations in biliary cancers. We talk about IDH1 mutation, FGFR fusions, they're very intriguing data, but also HER2 amplification, which are more common in gallbladder cancer than in other biliary cancer. And this is actually one of the lessons here on the slide here, that not all biliary cancers have the same the molecular alteration pattern. Intrahepatic cholangiocarcinomas are very rich in mutations like IDH1 and FGFR fusions, and gallbladder cancers have a higher prevalence of HER2 amplification, which really could be a target for what we've talked about, HER2 targeted therapy. There's even a trastuzumab deruxtecan, so T-DXd basket study, which had one pancreatic cancer and 2 biliary cancers, a gallbladder cancer, and a cholangiocarcinoma. And you can see here that this initial data, there are some responses anecdotally seen in these cancers. So that is an interesting target, and I hope that we'll see more data in these rare tumors, pancreas cancer, HER2 amplified, gallbladder cancer, and cholangiocarcinoma too. Now, HER3, which Dr. Koo introduced as one of the members of the HER family, EGF receptors HER family, has also evolved as a new target. HER3 is interesting because it has a defective kinase domain, so it really it gets its biologic activation by dimerizing with other EGF receptor or HER family members, and activates downstream signaling pathways. We have a lot of data actually from breast cancer, where the HER3 activation is linked to resistance to EGFR receptor antagonists, including tamoxifen. And due to the fact that we now have antibody drug conjugates that can target HER3, it's actually evolving as a therapeutic target. In colorectal cancer, which I like to focus on, we have known that the HER3 alterations are present in terms of mutations in our panels, but more importantly, I think, for our therapeutic approaches, is that the majority of colorectal cancer patients, the tumors actually have relatively high protein expression of HER3. More than 50% of cancers have IHC 3+ and 2+. So this is clearly, based on all we know, an interesting target for therapeutic approaches. And we do have a novel anti-HER3 antibody drug conjugate, patritumab deruxtecan, which is really the kind of sister molecule to trastuzumab deruxtecan. So T-DXd here is P-DXd, which has the same biology, same chemistry, with this proprietary drug linker, the payload linked to the patritumab, the anti-HER3 antibody, and can really kind of deliver the cytotoxic agent into the HER3 overexpressing or potentially even low expressing colorectal cancer cells. And there's a study ongoing right now in kind of a phase 2 study with 2 stages, that looks at patients with high expression HER3 plus, HER3 3+ and 2+ plus ISH positivity, or lower expressors, similar to the drug development strategies we've seen with T-DXd in gastric cancer, colon cancer, and breast cancer, actually. So this is a very interesting slide, which actually Dr. Shitara provided, and I thank him for that, which shows us the landscape of available and emerging targets and treatment approaches in GI cancers. And you can see that gastric, colorectal cancer, biliary, pancreas, etc. There are a lot of white space here, and I hope that we can fill this over time. But as you can see, the ongoing trials in orange, brown here, there's a lot of ground that we're covering right now with our trials. And I hope that we can see the green space here more and more filling up the whole picture of this matrix here, because this would really be what we like to see for our patients. And we've talked about NTRK and Pembrolizumab, MSI high and TMB high, tumor mutation burden high cancers before. It's an exciting time to be in GI oncology right now. So to conclude, we've seen that HER2 is an important target for various GI cancers, and I do believe, that's at least what we do in our shop, HER2 testing should be part of the initial workup of GI cancers. I prefer a comprehensive molecular profile testing for all advanced cancers to really put patients on a track toward, and really explore the treatment options that are available for patients, including, if available, clinical trials. Trastuzumab-based first-line treatment is standard of care HER2 overexpressing gastroesophageal cancer. The Tcga data really were the ones that opened the door for targeted therapies in gastric cancer with novel HER2 target approaches with great promise. In particular, I think the data we've seen with ADCs, the T-DXd, really interesting, in particular since this drug actually works in pertuzumab pre-treated cancers. We have seen data in colon cancer and in gastric cancer that even patients have been pre-treated with trastuzumab-based therapy, that they have the same likelihood of response with this antibody drug conjugate. In colorectal cancer, we have various approaches. We have trastuzumab papatinib, pertuzumab, or T-DXd. They're all listed as treatment options in NCCN guidelines. And HER3 is a really interesting patient population because a lot of patients with metastatic colorectal cancer have HER3 positive cancers, high prevalence of HER3 expression. So that's an interesting target. And of course, we all talk about precision medicine. It's not the future, it's actually present right now. This is what we're doing right now, and not just in academic settings, but also in a community setting. So let me talk about a patient that I actually had in my clinical practice. I had a 68-year-old female patient, had iron deficiency in the left supraclavicular lymph node. We biopsied the lymph node. It was actually metastatic cancer consistent with a colon primary, so kind of an atypical pattern of metastasis, and subsequent colonoscopy revealed hepatic flexure mass. She never had prior colonoscopies, and further workup showed widespread metastatic disease beyond the midline lymph nodes to liver, omentum, and lungs. She had peritoneal disease, had some evidence of partial bowel obstruction too, and was not considered a candidate, let's say, for bevacizumab therapy because there's always the idea of potential surgical intervention. So next-gen sequencing actually showed the patient to have HER2 amplification. We did not correlate that with immunohistochemistry at that point because the initial workup was the NGS. MMRP, RAS, and BRAF wild type. So this patient initially received FOLFOX chemotherapy. I mean, that's what we talked about. It's one of the standards of care. Hepatic flexure is right side. We didn't want to use bevacizumab, so no targeted agent. She had a response, but had complicated course, had a biliary obstruction due to some lymphadenopathy, bowel obstruction. She had a diversion. We talked about, so what's our second line treatment? And, again, it was not easy for her to tolerate chemotherapy. So even NCCN guidelines in these settings actually talk about, HER2 targeted treatment options are valid. So trastuzumab-based treatment with pertuzumab or lapatinib based on the available phase 2 data that we have, or trastuzumab deruxtecan, T-DXd are all part of the mix in our portfolio that we can use at this point in time. The patient actually in this case here received trastuzumab pertuzumab, because T-DXd at that point was not yet approved, was still in clinical studies. And you can see here after 2 months of therapy, really interesting, very nice, and actually a prolonged response. The patient had a duration of response of about 6 months before she progressed. So that shows you the power of HER2 targeted therapies in this setting. So that's something we need to think about. The NCCN guidelines did put this into place for a good reason. So to summarize what we see with HER2 metastatic colorectal cancer, HER2 amplification is seen in about 3% of metastatic colorectal cancer. I mentioned that there is a higher prevalence in RAS and BRAF wild-type cancers, left-sided cancers, patients who had a progression on EGF receptor antibody therapy right up front. This can refine the patient population where we expect them to be HER2 amplified or HER2 positive. But again, I would favor upfront testing for HER2, preferably with a next-gen sequencing profile, which gives you a lot more information. And this is because we know it's a predictive marker for anti-HER2 therapy. And coming back to the slide that I showed you earlier, we have an abundance of data, and the consistency of these data actually is interesting because however you target HER2, it really seems to work. And I think the strongest data we have seen so far, and I hope we see more emerging data, and further analysis of the Destiny CRC study seem to emerge with T-DXd, high response rate, in particular in patients also with pre-treated HER2 targeted agents. So second-line studies have shown objective response rates to HER2 targeted therapies with various different approaches. And, the NCCN guidelines actually say, if you have a patient who's not a candidate for chemotherapy, like a doublet chemotherapy with or without a targeted agents, and you have a patient with HER2 positivity, you could consider HER2 targeting therapy as a first-line treatment option because normally a combination of trastuzumab, pertuzumab, T-DXd are better tolerated than standard chemotherapy. So putting this into the mix of what we see in colorectal cancer, this is a slide that I commonly use to look at the factors that influence treatment choices. And more we see this box of molecular characteristics expand, and HER2 really has its place to really identify patients with HER2 positive disease because we have treatment options for these patients. So our portfolio of drugs that are part of this puzzle here is expanding. I need to expand this puzzle actually because we have a lot of new targeted agents, PD-1 antibody therapy, anti-BRAF treatment with encorafenib, and again HER2 and hopefully HER3 targeted therapies in the future. So with that, I'll kind of close my presentation. I want to look at the audience questions that we might have. Okay, so there's this question here. how do you see the role of HER3 targeted agents fit in the colorectal cancer paradigm? And I actually want to see what Dr. Shitara thinks about it, because I have my opinion about it. And Dr. Shitara, what do you think could we expect for anti-HER3 therapy in colorectal cancer?
Yeah, thank you for asking the question. Some small studies suggest that the HER3 expression also associated with the resistance to anti-EGFR therapy. So I think this is a very important target for additional new treatment. So usually want to therefore other HER3 ADC is a very good one because it already showed a very good activity in HER3 positive breast cancer. Actually, response rate is around 40%. So I expect similar response in HER3 positive gastric, HER3 positive colorectal cancer, as well as other tumor types. So we should wait for further results from ongoing clinical trial.
I mean, the clinical trial evidence is currently being generated. I hope that we see, and it's intriguing for me to see that the same mechanism in terms of chemotherapy delivery is being used as in the HER2 ADC agent T-DXd that we've been using. So the high prevalence of overexpressing HER3 in colorectal cancer, I think, is quite promising, I hope. You know. Jeffrey, what do you, in the other question that comes up, what's the most active HER2 targeted therapy in colorectal cancer that you would think is there? You know, because, you know, we have, you know, trastuzumab, pertuzumab, trastuzumab, lapatinib, trastuzumab, tucatinib. We have, you know, all the antibodies that actually Dr. Shitara mentioned, you know, margetuximab, you know, in clinical trials. And we have T-DXd. So we never had a, you know, comparison between these agents, but give me your thoughts about, you know, what do you think could be the most active HER2 targeted approach?
Yeah, I mean, clearly I don't have the answer to that question, and I think that's actually a good thing, because I think to your point, and I think, you know, the slide you showed was really, you know, kind of eye-popping in the sense that, you know, in a late line setting, you know, we have treatments that have response rates of anywhere from 30 to 50%, and there is some durability to the response. I mean, I think, you know, so I think there actually are multiple, you know, interesting combinations, and you know, I think that the only way to definitively answer this question if we ever did a head-to-head comparison, which I'm not necessarily suggesting, but I think more to the point. I mean, I think there are multiple treatment options available for patients, both now on a standard basis based on the NCCN guideline recommendations, but also I think on you know, if a clinical study is available, and I think, you know, what's most appropriate for a patient is probably based on that person's performance status and kind of their characteristics. You know, trastuzumab deruxtecan, I mean, at the end of the day, it does contain cytotoxic chemotherapy, so there are chemotherapy-like side effects. You know, trastuzumab lapatinib, trastuzumab pertuzumab, those drugs also have, you know, diarrhea as toxicities. So that may influence in some part, you know, what we may ultimately select for patients. I think certainly something that's intriguing is that we know that trastuzumab deruxtecan, at least in gastric cancer and even in the colon cancer data, can work in patients who've previously, you know, received a trastuzumab-containing regimen. So, you know, one combination I could think of is maybe, you know, trastuzumab with lapatinib, or trastuzumab with pertuzumab, or maybe even trastuzumab with tucatinib in the near future, and then potentially if patients progress on that, then considering, you know, trastuzumab deruxtecan. The question will emerge at that point, you know, do we kind of begin to follow the gastric cancer paradigm? When someone progresses on one line of HER2 therapy, do we biopsy to confirm HER2 positivity? You know, again, I certainly don't have the answer to this question, but I think these are, I think it's encouraging, and it's great that we are able to have even raise these questions, because it really suggests that for the small proportion of patients who have HER2 positive tumors, that this is really opening up an entirely new field of treatment options for them.
So I agree.
It's so interesting. Dr. Shitara, please.
Sorry. I agree with the comment. So the sequence might be very important. T-DXd showed activity even after HER2 targeting therapy like trastuzumab in gastric as well as the colorectal. But maybe unmet patient population is a patient with HER2 as well as the last pathway activation. these patients may not be good candidate for trastuzumab and other combination. T-DXd data was also limited in RAS wild type in phase 2. We have some patients in phase 1, HER2 as well as RAS mutation, but maybe one of them achieved the response, but the others do not have a response. So maybe we need more data or more newer combination to overcome RAS activation even in HER2 positive population.
So it's very interesting that we talk about all the activity in terms of drug development, clinical trials in this small patient population for HER2 positive colorectal cancer. Because I remember, I'm old enough to remember that when trastuzumab was a kind of drug in development in breast cancer and later in gastric cancer, we actually knew that there were about 2 to 3% of patients that had HER2 positive colorectal cancer. And at that time, the decision was made more or less from a business perspective, not to develop trastuzumab or trastuzumab-based combination in colorectal cancer because it was not considered interesting enough because it's only 2% of patients. And nowadays, we actually target much smaller patient population when I see what's happening in lung cancer and, of course, in colorectal cancer, all these different approaches which benefit patients in terms of personalized therapy, of course. There's another question that I'd like to move forward to Dr. Shitara, actually. Is HER2 overexpression a resistance marker to EGF receptor antibodies? You mentioned this for HER3 to some degree, but what about HER2? Because that would actually also be another point to test for HER2 upfront, because in patients who have, let's say, left-sided RAS wild-type tumors, would HER2 presence be a marker that would sway away from using EGF receptor antibodies?
Yeah, actually, there are several retrospective study to investigate resistant marker in cetuximab panitumumab treated population, and here, not a few cases showed HER2 amplification, and this was also confirmed in preclinical study led by Salvatore Siena. So I think HER2 is one of the possible resistant marker for EGFR antibody. That's why it is better to use anti-HER2 therapy in earlier lines of treatment.
Very good. Dr. Koo, any comment from you in this regard?
No, I agree. I mean, I actually think that, this is, the question is, when do we take very compelling and biologically plausible retrospective data and use it in a use it in a validated fashion? And it made me think about the SWOG study that you presented earlier on. I think the challenge is that the control arm is I think it was cetuximab with irinotecan, and it's also using trastuzumab containing combinations, that are now in the NCCN guidelines. So I mean, that clearly is there are several challenges to accrual, as you had pointed out.
So when we talk about using retrospective analysis of data as, to guide our treatment approach, it's similar to what we've seen with the KRAS mutation status as a negative marker of sensitive or a marker of resistance for EGF receptor antibody therapy. Because we never had prospective studies for cetuximab, panitumumab. We looked at the retrospective analysis of prospectively collected data. And I think, for HER2, it's the consistency of the approaches that we see consistent data in terms of response, but also for anti-HER2 targeted agents, but also resistance to EGF receptor antibody therapy. So I do strongly believe we can use these retrospective data to guide our approaches, especially when they're very consistent. So I think we've really covered a lot of ground today, really going through the field of GI oncology. It's really exciting to be a GI oncologist. I think that's my takeaway from the last years. And I'm also excited that we've seen a lot of advances, especially in upper GI cancers, immunotherapy, HER2 targeted approaches in the year that was dominated by a pandemic, by COVID. So cancer doesn't wait for COVID, and we've found ways to move research forward, educate each other. And these programs that we're using here right now are part of this, to educate us in a virtual way to really enhance patient care with all the new advances that we've seen in personalized therapy. And I really thank Dr. Shitara and Dr. Koo that really provide an international forum. Cancer has no borders. Cancer is a national problem. We are resilient to a pandemic, and we can move cancer care forward in cancer research. So thanks again. Thank you very much for joining us.
This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peer Review Institute for Medical Education.